We as genetic counselors have a dedicated time to really dig into the family history to figure out if a cancer could be hereditary or not. We know that others on our team are more focused on working up a treatment diagnosis or focusing on some other aspects of the patient's care.
That's Lindsey Byrne with the Ohio State University Comprehensive Cancer Center. We'll hear more from her later in the show. Today on Cancer Buzz, germline and somatic testing for patients with prostate cancer. Welcome back to Cancer Buzz, the show that delivers fresh perspectives and the latest in cancer care to the busy, multidisciplinary oncology professional. I'm your host, Summer Johnson. Germline and somatic testing can improve outcomes, but many patients with prostate cancer don't know about it. Our guests today are here to discuss how to get more patients into testing and how genetic counselors on the multidisciplinary team can help. Dr. David Gill is a medical oncologist at Intermountain Healthcare in Salt Lake City.
Over the past few years, with new PARP inhibitors entering the treatment landscape for metastatic castration-resistant prostate cancer, the role of precision oncology has really increased. Really, all patients who are eligible for treatment in the castration-resistant prostate cancer space should have somatic testing. That can present a challenge, particularly with patients who have bone-only disease or potentially their prostate specimen is dated. And so it's a complex space for the clinician figuring out when to do, solid tissue-based testing, liquid testing, or both. But it's important as we spend more and more of our clinical practice on somatic testing that we don't lose sight of how important germline testing is. And I really view them as a Venn diagram where there is some overlap, but they are separate and equally important components to treating prostate cancer.
Do you have any specific examples?
So if I'm seeing a patient, I may do tissue-based somatic next-generation sequencing, and that could reveal a BRCA2 mutation. And I've heard some clinicians say, well, I know for my treatment options now, this patient has a BRCA2 mutation. Why do I need to do germline testing? And there are two reasons. One is that just because it's on the NGS panel, we don't yet know if it's a somatic or germline mutation. And this could have important impact on the family for cascade testing. But two, not all inherited genes are picked up on a somatic panel. So HOXB13 is a great example. This is not a targeted gene. So it's not going to be on one of our somatic reports, but this can have really important information for family, including cascade testing. And the only way you're going to detect HOXB13 mutation will be through a germline panel.
Germline and somatic testing is the standard of care for metastatic prostate cancer, but almost 40% of patients aren't receiving testing. Why do you think that is, and how can a genetic counselor help close the gap?
I think part of the reason that germline testing is underutilized is in part due to some of the confines of a clinical practice. So when I'm seeing a patient, we'll review imaging, pathology, lab results, obviously address the patient concerns. We'll talk about androgen synthesis pathway and different treatment options and rationale for treatment. We only have 30 minutes or an hour to go through all of that. And so sometimes we just don't get to germline testing. Other issues can just be the logistics of ordering. And so we've created a nurse-driven pathway at my institution to help with that, to kind of make it foolproof or a safety net in case the clinician forgets to talk about germline testing, they'll have a nudge, and that's really increased our rates.
Can you tell us more about that nurse-driven pathway?
So in the NCCN guidelines, there are really good criteria for who is eligible, but they can be difficult to remember. So as a medical oncologist, what I remember is that any patient with high-risk disease qualifies. So that, of course, includes men with metastatic disease, but it also includes patients who have node-positive disease or another high-risk feature including T3, T4 disease, Gleason 8 or above, or PSA over 20. So the nurses I work with understand those criteria. And so if a patient meets those criteria, which honestly is just about any patient I see with prostate cancer in my clinic will, they will give the patient a heads up. Dr. Gill may discuss germline testing with you. Then at my visit, as part of our checkout, my nurse will ask, did you discuss genetic testing? If I didn't, that's a good reminder for me to discuss it. But if I did, they will then propose the orders. And when we collect blood for PSA or other lab work, they will also collect blood for the germline testing and send it off. So I really don't have to do anything other than consent and discuss it with the patient. And all the logistics are taken care for me by my clinical team.
What about genetic counselors? Are they meeting with patients?
We identified that our genetic counselors were overwhelmed with our volume of prostate cancer patients. So we previously sent every patient to genetic counselors first before getting tested. The issues were that only about 10% of our patients are going to have a positive germline test. And so that is a lot of bandwidth, where 9 out of 10 patients ultimately don't have a mutation. We also, about half of patients who consented to meet with a genetic counselor ended up getting testing. There's a lot on a patient's plate with scans, labs, et cetera, and a lot of them just didn't make the appointment. So we moved to more of a maternal practice where we, as the clinician, will test, and then if there's a positive result, we'll send them to a genetic counselor. So similar to how they would do it like in an OB setting.
What are some of the challenges you see here?
We first identified that we were really underutilizing germline testing in our patients, and we needed to improve it. But the second thing we noticed is that our patients who lived in a rural zip code were getting particularly low rates of germline testing. And part of the reason for that is in Salt Lake City, I only treat GU cancers, so it's easy for me to remember the indications for prostate cancer. But in our rural communities, we have a lot of general oncologists who may see 15 different cancers in one day. So that's a lot to ask for them to know germline testing for 15 different indications. So we sought to offload the doctor a bit, and they know now when they're seeing a patient, the nurse will come to them and say, hey, patient X qualifies for germline testing, make sure you include it in today's visit. And I think that's really helped increase our overall rates of testing, but it's also improved our germline testing in rural zip codes, which is a known healthcare disparity for Utah.
What can you share with your colleagues about patient education and the impact germline and somatic testing can have on outcomes?
One of the biggest knowledge gaps I've seen with patients is that a lot of them feel this will only affect their sons. And so one of the biggest pieces of education I personally do is talking about Angelina Jolie. I think she's the most well-known, at least American, with a BRCA mutation, and discussing that some of these genes could also affect daughters as well as, future grandchildren, and, explaining that some of this testing could have a therapeutic benefit for you, but there are very real potential health benefits in your family line if you tested positive. The other thing I say is that there is a 90% chance this is going to be negative. When you get a diagnosis like this, almost always your family assumes you gave them a gene. And so 90% of the time you can get testing and say, you know what, I didn't give you these. And that can be reassuring for them as well.
Any final thoughts to share with your colleagues?
The one piece I would say is that a lot of times we'll first do somatic testing and have no mutations detected or no HRD mutations. That doesn't mean there isn't a germline mutation present. The panels test for some different genes. And so I'd really advocate, even in your patients with a negative NGS panel, please still consider getting germline testing in those patients.
Next, we turn to Lindsey Byrne, a licensed certified genetic counselor at the Ohio State University Comprehensive Cancer Center, the James, in Columbus.
I think it has a lot to do with education on the topic and healthcare providers being aware that genetic testing is standard of care for men with metastatic prostate cancer. So making sure that the word is out about genetic testing and that it is a tool that can help with treatment for individuals. Genetic counselors can help with that because really some of our special skills is really educating patients and populations about tools in regards to genetic testing for patients. And so we have the ability to help get the message to community, out to patients, working with hospitals and healthcare providers to make sure all understand that genetic testing, whether somatic or hereditary, is an option for patients.
How can advancements in germline and somatic testing influence the treatment landscape for metastatic prostate cancer?
So, when individuals test positive for an underlying hereditary or somatic mutation in a gene, that could give potential treatment options that weren't usable before. And so, patients then at that point have the ability to have other therapy options, which wasn't in the toolbox before, which is great. The other piece is what we have learned is individuals who fall into this category where they do have a mutation in somatic or hereditary mutations that we actually have new therapies for, they tend to do better than those who don't. And so we see a little bit better success rate as well.
What are some of the challenges you've seen as a genetic counselor?
Yeah, I think the biggest misinformation that I hear out in the public when I'm meeting with patients is that men cannot inherit cancer risk from their mom's side and pass on to daughters. So when we take a family history and thinking about risk for family members, all cancers are important. So we want to know for, individuals with prostate cancer, we also want to know that there's female breast cancer or ovarian cancer or other types of cancer because we get half of our genetics from mom and half from dad, regardless whether there's no prostate cancer on mom's side. We still want to be aware of the cancer history on mom's side and that you could, if you have prostate cancer, could pass that genetic risk on to a daughter because she gets half of your genetics from you and half from her mom at that point.
Tell us about the benefit of including a genetic counselor on that multidisciplinary care team.
We as genetic counselors have a dedicated time to really dig into the family history to figure out if a cancer could be hereditary or not. We know that others on our team are more focused on working up a treatment diagnosis or focusing on some other aspects of the patient's care. And we're really looking at the patient as a whole in regards to their family as well. We want to make sure that we discuss as much as possible, not only for their genetic information, but how can we take care of their family members as well and prevent cancer risks for them. So we really have more time to focus and make sure that we're figuring out where a hereditary mutation is coming from, which side of the family, our siblings at risk, our children at risk, and what can we do to help them? Because we know that individuals, yes, they're dealing with a diagnosis of cancer, but the first and foremost, the first thing that people say to me when I sit down with them is, all right, I have this figured out, but what does this mean for my family? They're really worried about their family. And that's where our focus is to help take care of that.
Which patients are the most appropriate for genetic testing?
Yes, when it comes to prostate cancer, the individuals who would meet national criteria, meaning individuals would have very good insurance coverage for testing, would include individuals who have prostate cancer that's considered high risk, very high risk, metastatic in the regional sense, and metastatic to another organ. So those four categories, which can also be broken down by if you're told that you have a Gleason score of 8 or higher. So anybody who has just that diagnosis, and then if your diagnosis is not in one of the higher categories, or maybe it's more moderate or low, And then you have family history of other types of cancer, whether you have some prostate cancer in your family, breast, ovarian, pancreatic cancer, or others. Those individuals could also be appropriate for genetic counseling and or genetic testing.
Any parting words for your colleagues?
I think all prostate cancer patients should know that genetic testing could be an option that might be appropriate for them, and to ask their physician if talking through genetic testing with a genetic counselor would be appropriate for them. Really, our main job is to educate and talk about what genetic testing is and how it can impact a patient and their family. Just scheduling with a genetic counselor does not mean that you have to test. I actually really enjoy just having conversation to make sure that patients understand the genetic information, because we know it can be very complicated. And sometimes patients decide after we talk that they don't want to test or they're not ready to test, and that is okay too.
Thank you to our guests today. You can head to the show notes for more resources on genetic counselor integration in routine genitourinary care. This episode was made possible by support from AstraZeneca, Johnson & Johnson, and Pfizer. If you found today's episode helpful for your work, please share it with your colleagues and be sure to follow the show so you never miss an episode. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.